Well, thank you so much. And I am thrilled to be here. As I was saying to Veronica and Courtney, as you all were coming on, Stanford has a very long history of paying close attention to these issues of language access. And at a time when nobody else was doing anything, was working on these issues way back in the 1990s, in the early 1990s, maybe probably back into the 1980s. So, you work for a wonderful organization. Which is not to say that there couldn't be some improvements. I don't know what they would be. You would be the ones who would know what they would be. So when I spoke with your organizers and we talked about, what they would like to talk about, what they would like me to talk about today, there were a couple of issues came up. One was that they told me that you are working with trying to help people learn how to work effectively with interpreters and to work more continuously with your dual role interpreters. At the same time, I was also told that you would be interested in hearing a little bit about how you get systems to change, how you get leadership engaged with this issue. And to be honest with you, either one of those is an hour chat, at least. And so we kind of decided to go with the latter, to talk about how do you make systems change. And just so you know a little bit about my background, my first career was in international rural development, but I ended up getting into this work as an interpreter through the back door in the early 1990s, as many people did. And but my interest in systems change has really led me to work more around training interpreters, training providers to work with interpreters, and then also to help organizations like yours, medical systems, healthcare systems around the country, improve their language access programs. And when I started in the field, back in the early 1990s, we were still using, the 8-year-olds to interpret in oncology. And so there wasn't a field really. And one of the things that I had to learn over the past 30 years has been, how do you get big institutions to change? Working as an interpreter, as a freelance interpreter, and then as a staff interpreter. And then also, I have run a bilingual patient navigator program at Seattle Children's Hospital, has given me a good view into how do you get large medical bureaucracies to pay attention to things. So I'm going to share some ideas with you today. Please remember that these are kind of general ideas, and only you will know what applies to Stanford, right? Yes, Courtney, I see you.
I am sorry. I just want to make certain you are aware that Veronica is from Stanford. CPQCC is based at Stanford, but a majority of our members today are either clinicians throughout the state of California at
Oh,
very, very different medical centers and
okay.
institutions, and we have family members that are a part of this group. So
I did not know
I apologize.
any of that. Okay, good. Well, that's good to know. Even so, it's still useful to talk about how do you change big hierarchies, because whatever healthcare system you all are working at, or wherever you get your care, if you are yourself a patient, is a big bureaucracy, I guarantee you. And healthcare can be very hierarchical. And so sometimes it can be very hard to get change into these organizations. So with your permission, I'm going to share a little presentation that I call Romancing the C-Suite. Because sometimes that's what it feels like we have to do in order to interest hospital leadership in these issues of language access. So let me start out by talking about, what do I mean when I say the C-suite? Well, the C-suite are all those chiefs. So, the chief executive officer, the chief nursing officer, the chief medical officer, the chief information officer, the chief operations officer, the chief financial officer. Oftentimes, the senior leadership also includes somebody from HR, from human resources, and somebody from the legal department. And I have noticed lately that we are seeing a lot of hospitals adding to their senior leadership a chief for diversity initiatives. I don't know if that's the case where you all work, but these people are our natural allies. And oftentimes these positions are being opened at fairly high levels of leadership, which means that they get listened to and they have some power. So this is something that would be good. If you have one of these people at your institution, take them out to lunch, buy them chocolates, I don't know, bring them flowers, make friends with this person, because this person will be an important ally for your work. And let me start out with a short story here. So I came into this field, as I mentioned, from a career in international rural development. And I entered into this world with a very strong background in social justice. And of course, there's very strong legal backings for language access programs. But in the mid 1990s, the first group of hospital administrators that I talked to were a group in Atlanta, Georgia. Okay, so here I am, this relatively young woman, never been in an administrative position, talking to these senior administrators and telling them about how they were going to be in big trouble with the Office for Civil Rights if they did not, start providing language access. And civil rights, the Office for Civil Rights was going to come in and audit them and take away their federal funding, and they were going to be in big trouble. And anybody want to guess what the reaction was? Well, they laughed at me. I'm not joking. They laughed at me. And one of them said, dear, he said, which I thought was interesting. Dear, he said, the Office for Civil Rights in Georgia is so concerned with the complaints about civil rights violations based on race, they are never going to look into a civil rights complaint based on country of national origin. And they completely dismissed me. And I realized that part of my problem was, and I should have known better as an interpreter, that I was speaking to these people in a language they did not speak. I needed to speak to them in a language they understood. And I had completely missed the mark. So one of the things that I have learned in the years that came after is that one of the most important things we can do when we try to push our agenda of improving our language access programs, whatever that step might be, we need to make sure that we are presenting it in a way that makes sense to the people who are in decision-making roles. Does that make sense to you? Okay, even if we have to bypass our own passionately held social justice norms, this is not how we're going to get this done. So let's think about this from the point of view of senior leadership. Okay, senior leadership has an enormous number of competing concerns. Some of them come from inside the medical center and some from outside. For example, they're constantly concerned about whether they are fulfilling the law and regulations and whether they are meeting the requirements of accrediting bodies. If they aren't, if they're not following the law and they're not following federal regulations, they are going to be in legal trouble. And if they are not following the requirements of accrediting bodies, like what would be an accrediting body? The Joint Commission, or Der Norske Veritas, DNV. I don't know who accredits your institutions. But if they don't meet those requirements and they lose their accreditation, then they lose their federal funding. And that is obviously a big concern. They also have community demands coming from outside them. Communities want access. Communities want their members to be treated respectfully. Communities have lots of demands. And different groups in the communities have different demands. They're concerned about their legal exposure. Could they be sued? Obviously, a big lawsuit against a large medical center can go to millions of dollars, and that's money out of their budget that they can no longer use for operations. They worry about their reputation, especially in these days when hospitals really are competing with each other for patients who come with insurance dollars attached. So, they want to make sure that they are attracting the kind of people that they want to attract and that they're going to get their percentage of the population in their catchment area. That is the area in which people would be coming to them. They also, however, have a lot of pressures coming from inside the organization. Employee engagement, how happy are their employees or unhappy, as the case may be. Unions, I, again, don't know if your organizations are unionized, but oftentimes unions have demand and they have to be negotiating contracts with different unions. They have to worry about the physical plant of the hospital, right? Is it falling apart? Is there mold? All sorts of things that can shut down a hospital. They need to be updating with the newest equipment. They have to worry about their bottom line because there you go. It's a business and they're not out to make money, but unless you are a public institution and you're the county or the state is willing to let you go over budget year after year, which very few are, they have to worry about whether at the end of the year they have brought in enough money to cover their costs. And that's just part of running a business. And they're worried about medical excellence. How do their patients do? Are they having a lot of people dying from hospital-borne infections? Are they, does this hospital have a reputation for being the absolutely best place in the country to take your child, for example, if they have leukemia? So all of these pressures, all of these competing demands, and around those, we also have the constant change. Everything is changing all the time. The regulations are changing. The community demands are changing. The union wants different things. The physical plant is constantly deteriorating. That's the nature of physical plants. And a constant worry about patient safety. Above all of this comes patient safety, to make sure that patients coming into the facility are getting better and not getting sicker because of something that happened at the facility. So what's the bottom line here? The bottom line is that the C-suite has a lot of competing priorities. And that language access is a very important priority. But when you look at it from their point of view, you can see that your projects around language access are competing with a whole lot of other big concerns that they have in trying to run your health system. So, shall we just throw up our hands and despair and say, well, it's hopeless. There's nothing we can do. We just have to let it be the way it is. No, certainly not. But we do need to have a strategy, okay? A strategy for approaching the people who are making decisions, who are deciding which projects will go forward, what needs to be paid attention to, what can we leave till next year. And so that's what I want to talk to you about, is how to develop a viable strategy. So the first step in developing this, and by the way, if there's any questions, I'd be happy to take them as we go along. And I cannot see the chat. So if I could, but there's a limit to how much I can pay attention to. So I don't know, Courtney, could you keep an eye on the chat? And if there are questions, please interrupt me.
Of course.
Great, thank you. So long before you are going to approach anybody about anything, you need to do some research. Okay? First of all, you need to know you have to have a very clear idea of what you want to do. And you need to know who would be involved in moving that decision forward. So, for example, if you think that one of the things you need to do at your healthcare center is start testing the bilingual language skills of your bilingual providers, so the doctors who say they speak Spanish, and you think, well, maybe we better test that to make sure they really do. Well, then who are you going to need on board? You absolutely are going to need the chief medical officer. because this is going nowhere if you don't have the CMO on board. Let's say that you're thinking of going to remote interpreting, like you'd like to start a call center with your staff interpreters so that they can provide interpreting over the video. Well, then you are going to have to have the chief technology officer or the CIO, the chief information officer, because it's going to be, that's going to involve tapping into the hospital's Wi-Fi. So first of all, you have to know, who is it that you need to have on board to get your idea implemented? And then you have to understand, what are the organizations and those leaders' current priorities? I did a consultancy once with a major hospital system that shall remain nameless, because they were being sued for lack of language access. And so I was brought in to help them improve their programs to get this suit dismissed. And the first person I met with was the CEO. And I asked him, what were the top 3 things that worried him? And he told me that one of his big concerns was that his nursing ratios were all off, which means he didn't have enough nurses to cover the shifts for inpatient, and he had too many patients being assigned to each nurse. This is the kind of thing that could really cause problems on so many levels. And he also told me that at the end of the fiscal year, this was a hundreds of millions of dollars, possibly billions of dollars healthcare system. He said that at the end of the year, he was in the black by $10,000. $10,000. He was running this budget so close to the edge and so, that helped me understand that, any suggestions I made that were going to be very expensive were going to take a while to get implemented, because this hospital system did not have a lot of available cash. So understanding where the organization and the leadership, what they're currently focused on, will be very helpful in trying to decide how to present your ideas. Finally, you want to understand the organization's decision-making and budgeting cycle. So when do new projects get vetted? If they have money attached to them, they'll have to be written into the budget for next year. When does that happen? When are the deadlines? If, for example, the fiscal year starts in October, then probably they're working on budgets for the following year in January or February. So if you come to them in, late August with a really great idea for next year, if it costs any money, it may be too late to get it into the budget for next year. So you have to understand, how does the decision-making happen, and when do these big steps like vetting a project and putting it in the budget, when are those deadlines? When do those have to happen by? Okay, so you've learned about your institution. You know who you're going to need to address. You know when you need to do it by, and you know what their general concerns are already before you bring up your stuff. The next thing you need to do is to clearly define what it is that you're asking for. I can't tell you the number of language access projects that I've worked with where what the request was so vague that the administration didn't really know what people were asking for. It was kind of like, well, make it better. No, that's too vague. What do you want to do concretely? Why is this a good idea? Who is going to be involved? What staff is going to have to dedicate time to this? Or are you going to have to hire people? When is it going to start, and when does it end? Having an end point is important, and we'll talk about pilot programs in a little bit. Where is it going to take place? In just one department? In just one facility? Throughout the entire system? You need to think about not only the where in terms of physical plant, but where in terms of departments. And here's the big one. How much is it going to cost? Remember, these senior leadership are responsible for maintaining your system financially viable. And so they have to ask, what is this going to cost? It doesn't mean they're necessarily going to turn it down, but they're going to need to work this into the budget. So you need to think about these things before you go and make a presentation. Before you present an idea, you need to have thought this out. The next thing you want to do is to enlist allies to help you present this to the senior leadership. And, as I said, healthcare is very hierarchical, and so you absolutely have to go to your manager first. You can't skip over the manager. That's considered very bad form. Your manager needs to sign off on this, and the manager must be on board. The other thing that will help you a lot are people that we call doctor champions. It may not be fair, but it is the case that doctors simply have a lot more power and a lot more say in healthcare than, say, for example, interpreters. And so we know that there's a lot of doctors out there that care about these issues passionately, and we need to make allies of them. Make sure that, we bring them in on what we're doing. I see that you have done that already, which is fantastic. And doctors, know that your voices can be absolutely critical in getting new programs involved. When a doctor says, I cannot be expected to do my job without support from a qualified interpreter, just as you wouldn't expect me to do my job without access to the lab, that is a powerful statement. So we love you, Dr. Champions. Go out and find everybody out there who are physicians who like our work, okay? Get them involved. The other people who are wonderful allies are nurses, because I'm convinced that 90% of what actually happens in healthcare happens because of nurses. Nurses, I always tell my interpreting students, if you have a problem, go find a nurse. The nurses will fix it. That's what they do. So nurses bring my experience has been a wonderful mixture of understanding the reasons behind, what needs to happen, but also very practical knowing how to make things happen. So find your allies, whoever they are. If you are running the interpreter service department, don't think you have to go this alone. And I'm thinking now that, we may have a new ally if your hospital is starting a diversity and equity and inclusion program and has employed somebody in that position. This may be, a new ally for us. Again, sit down and talk with that person, see whether they would back your initiatives. Okay, so now we've got our allies. We know exactly what we want to do. We've got our allies. Now we have to prepare our arguments. Why should they be interested in our project as opposed to all the other projects that are going to come before senior leadership? Well, my first thing is to use numbers. Administrators love numbers. Okay, so if you can say, for example, and again, I don't know where you are in your situations, but if you could say, for example, we collect information on patient language needs. We know that we have X number of patients who need an interpreter. And last year, we know that we saw X number of those people. But we also know that we didn't provide interpreters to those people. We only provided interpreters to 10% of those people. I mean, that number, it just speaks volumes. So the more you can get data to share with senior leadership, the more seriously they will take your project. And sometimes it takes a little while to get the data. You may have to spend 6 months collecting data, but it will be worth it when you're able to go in and talk to, senior management, and you've actually, you've got all your numbers right there for them to see. It also helps to cite research. So when I first started in this field, there was essentially no good research on any of this. People confused trained interpreters with untrained interpreters and translation with interpretation. It was just a mess. You really couldn't compare anything. But nowadays, there's a really good there is really good research out there to back up the things we want to say. For example, we can show that research shows that language barriers lead to unnecessary care, and there's a citation, to worse patient outcomes, there's a citation, to more expensive care, that it takes more money to take care of patients that are limited English proficient when we don't provide an interpreter than when we do provide an interpreter, even if we count the cost of the interpreter. And again, there's some research. So when you're putting together your arguments, go out and see what research is out there. Remember that doctors in particular are trained on the basis of research. And so the more that you can back up what you're saying with peer-reviewed research out of serious journals, the more seriously they will take what you're trying to say. Stories are also good. Stories give a human face to things, but it's very easy for senior leadership to write stories off as being anecdotal. Well, it just happened once. That's not going to happen again. But if you've got research to show, no, if you're saying our LEP patients are being intubated at twice the rate of similar cases who are English speaking, I mean, that's a piece of data they can't ignore. You can tell the story about somebody who got intubated because they were LEP, but if you can actually show them that LEP patients are twice as likely to have that happen, that's a piece of data that they need to pay attention to. And by the way, there are several good bibliographies of research out there that I could let you know about. You could, through the National Council on Interpreting in Healthcare, up on our website, we have a couple of different bibliographies of annotated bibliographies of research in this field, which could be helpful. Okay, so you're going to use numbers and you're going to cite research. So again, we're having to, take some time to get that data, take some time to go out and pull together some research. Your third step is you have to know about the relevant laws, regulations, and standards. Again, remember that big circle I showed you. One of the big jobs of senior leadership in healthcare is to make sure that the institution is complying with the law, complying with federal and state regulations, and meeting accreditation standards. So what does that mean? If you all don't know already, then you should invite me back for another presentation to talk to you all about the legal and underpinnings for language access. Title VI of the 1964 Civil Rights Act says, and I'm paraphrasing here, if you get federal funding of any kind, you must provide equal access to your services. And a 1974 Supreme Court case recognized that language is an aspect of country of national origin. So you can't discriminate on the basis of race, color, or country of national origin. And language is an aspect of country of national origin. Bottom line, you take any kind of federal funding, you have to provide language access. The American with Disabilities Act is very clear that hospitals and clinics must provide reasonable accommodation for patients with disabilities. So for a patient who is deaf or hard of hearing, having an interpreter provided is a reasonable accommodation. It's very clear. Section 1557 of the Affordable Care Act is the civil rights section. And it basically says the same thing as the 1964 Civil Rights Act. But interestingly, new regs are coming out before the end of the year. That's what I hear. They're in the last stages of being vetted. So they say they're coming out before the end of 2023. And these regs are very clear about how do you define what a qualified interpreter is. Whether it's okay to use kids, the answer is no. You may not use children under the age of 18 to interpret in clinical settings unless it's an emergency and the child is the only person who speaks the non-English language. It also talks about what's required if you're going to use family members to interpret. So it's pretty clear about what hospitals and clinics need to do. Also, if your hospital or clinic takes Medicaid, there may be language in the Medicaid contractual language that requires you to provide language access. I know that in California, Medicaid is contracted out to what are they called?
Is it medical?
Yeah, it's called Medi-Cal, exactly, Medi-Cal. And the state actually has contracted the provision of these services out to these organizations, healthcare insurance organizations, who then subcontract with hospitals and clinics. So the state basically says, well, we are requiring our insurance companies to make sure that language access is being provided as part of the amount of money that we're paying at a capitated rate per person that they have signed up for their insurance plan. And the insurance plans say, we pay a capitated rate to our hospitals and clinics to provide actual care to these patients. And as part of that capitated fee, we require them to provide language access. And then the hospitals and clinics turn around saying, this is an unfunded mandate. They're not paying us extra to provide an interpreter. But the institutions and the state say it's all included in what we're already paying you. So it's kind of a mess, but the bottom line is that there may be language in your Medicaid contract that requires your institution to provide language access. Also, depending on who accredits your institution, whether it's Joint Commission or DNV, there's often requirements and language in their accreditation requirements that address language access, address being able to prove how anybody who does their job in your system, how you know that they're qualified. So, for example, if I know that Joint Commission has that requirement, so you would have to be able to show, how do you know that that family member that you just used to interpret is qualified to interpret? And if you can't, then you're not meeting the accreditation standards. There also are many state laws and ordinances. California has hundreds and hundreds and hundreds and hundreds and hundreds of these things, depending on where you are. I'm trying to think of where you can find them all in one place. I did some research for the Department of Health and Human Services. Is it DHS, Department of Healthcare Services in California, where we summarized all of these laws. Unfortunately, the report was never published, which is a pity. So the best place to go probably to get this information would be the National Health Law Program. They have wonderful resources that summarize all the legal requirements related to language access by state. So you can see what's going on in California and in your locality. All righty. Okay, so you got your numbers, right? You've looked up all your research so you can, cite those studies. You know about the relevant laws and regulations and standards that apply to your institution and how they are going to be forwarded, how they are going to be moved forward by the project that you want to do. The next thing is you need to take a look at the current and projected demographics of your patient population. And the place you want to go do this is the US Census. So take a look at this. If you look at census data and you look at this is a counting of people who on the US Census said that they speak English less than very well. So you can check off how well you speak English. Anything less than very well is considered limited English proficient. In 1990, 14 million people in the United States, about 6.1% of the population, said that they spoke English less than very well. In 2000, it was 21.3 million, or 8.1%. In 2010, it was 26.4 million, or 8.6%. And in 2020, it was 28.9 million, almost 29 million people in this country who say they speak English less than very well. This actually goes down in terms of percentage, but you got to remember who was president when we did this census, and there's some questions about how well this census was done. Enough said. But the long and the short of it is, once you start looking at census data, and if you can break it down by county, for example, your organization's catchment area, you can show how the need for language access is just going up and up and up. And although it's not going up as steeply as it did between 1990 and 2000, it's still going up. This is not a concern that's going to go away. It needs to be addressed. All right, you've got your numbers, you've researched your research, you found out all about the relevant laws and regs and standards, you know about the current demographics of your patient population. By the way, another group to look at here is to talk to your local or state refugee resettlement organization, because they can tell you who is in the pipeline, what groups are in the pipeline to come into the United States as refugees that you are now going to have to provide language access for. So, as you know, when I first started, nobody needed interpreters in Dari and Pashto. Afghani languages were not even on the map, not even on the radar. Now, after the United States pulled out of Afghanistan, pulled the military out of Afghanistan, there has been a huge flood of Afghani refugees into the United States. Afghan refugees into the United States. And suddenly we all need Dari and Pashto interpreters. And, we needed to have started years ago preparing people for those roles. So talking to the refugee resettlement organizations can also help you know and prepare for who's coming. The final thing that you need to be aware of is you're going to have to talk about ROI. And so what the heck is ROI? I never thought I would be talking about this. I'm into social justice, not running a business, but return on investment, ROI, talks about how much you're going to pay and when are you going to get a payback for your investment. What's your benefit for the cost? And you will need to think about this. Now, the return doesn't have to always be financial. Okay, there are other things that are of concern. Like a return can be knowing that we're not going to get sued. A return can be knowing that we're going to pass the Joint Commission accreditation visit. The return can be getting more patients to come to our hospital. So return doesn't always have to be financial, but we do need to say, for the amount of money that we're going to be investing in whatever project it is that you're thinking about, what benefit are we getting back out of that? What do we get back for what we invest over a specific period of time? All right, numbers, research, laws and regs, current and projected demographics, and ROI. And finally, you want to be able to link your project to whatever is the current organizational priority. I'll bet some of you have been in healthcare a long time. Am I right? I can't really see any of you, but I see Courtney shaking her head, yes. So you've probably seen, 35 years, holy McGillicuddy. Okay, yeah, you've got experience. And so you're probably aware, and you probably noticed how what is the current organizational priority keeps changing, right? So is it patient safety? Is it patient experience? Or is it community responsiveness? Is it a lower bounce back rate? That means the rate at which patients come back to the hospital within a week of having been discharged for the same thing. That's not a good thing, by the way. High bounce back rates are a problem. Is the hospital concerned about lowering the no-show rates so that when they make somebody an appointment, the person actually shows up for the appointment? Are they worried about competing more effectively with the hospital across town? And here's the newest one. This is what I'm seeing nowadays, is hospitals are becoming very concerned with diversity, equity, and inclusion. You need to know what it is. What is this year's worry? What is this year's priority? I remember when I was at Seattle Children's Hospital and, we were talking about doing work with patient navigation to improve quality of care. Well, all of a sudden, they didn't care about quality of care. Suddenly, everything was about patient safety. That was fine. We could completely recast everything that we were doing and showing how it very truthfully was going to improve patient safety. Things that we could not get funded on talking about other benefits of it, once we linked it to patient safety, suddenly those projects were getting funded. So what is it that your hospital or clinic is focusing on as an institution? That you want to try to link your project to whatever that is. And believe me, is language access, it's easy to link language access to patient experience, to patient safety, to community responsiveness, to competing with the hospital across town. I mean, it is easy to link language access to all of these things. All right, moving along. There are some things I would caution you to only bring up with extreme care, and maybe not at all unless you feel you're not getting anywhere. One of them is lawsuits. There are and have been, sadly, the need for lots of lawsuits around language access, and I've listed a bunch of them here. And it doesn't stop. I mean, even this year, ACLU is suing a hospital because they let a patient die of sepsis. They sent him home. He came back the next day and died of sepsis. A Navajo elder, and they provided no interpreter. It's still going on. And you can take a look at, some of these settlements, $71 million, $1.2 million, $900,000. These are not small settlements. I say use these arguments with very extreme care because administrators are likely to dismiss these as it's not going to happen here. In addition, for some of these, they might say, well, $350,000, you know what? It's cheaper to pay out the $350,000 than to improve the language access program. And you don't want them to be able to make that argument. So be very careful with these arguments. Another thing that I have seen done when it got to the point where hospitals were just non-responsive is going to the press. If there's back here, this egregious, back here in 2002, there was a girl, I think she was only 12 years old, died of a fatal appendicitis, and they were using her to interpret for her parents. And she died. And that did go to the press. So bringing in the press is kind of a last-ditch thing. If you have a really egregious circumstance and the hospital just absolutely won't pay attention, this is certainly a route you can take. But remember that as an employee of the healthcare system, you're not supposed to be talking to the press. And so you put your job at risk. And in addition, an organization that goes to the press and blows the whistle will not be the organization that the hospital goes to help it solve its problems. You can't be both the whistleblower and the problem solver. So if it comes to the point of involving the press, you'll have to try to figure out who can you get them to bring in to solve the problem, because they won't trust you anymore. But sometimes this is necessary. There are some things to realize that administrators absolutely hate. They hate whining. Don't just go and whine. Oh, we don't have enough interpreters. Show me. prove it. They hate problems with no solutions. So always go in, if you want to present a problem, then present the solution. Show how you're going to fix it. They hate expensive solutions. And sometimes expensive solutions are necessary, but just realize that they will have to be budgeted for. So you're not going to get it next year, maybe the year after. But they're going to have to figure out how to pay for it. They don't like short-term thinking. They want solutions that are going to last over time. So that's one of the reasons it's worth investing time up front to do your research and clearly define what it is you want to do and why you think it's going to make a difference over time. They really hate being publicly embarrassed. So don't do that unless it is your last ditch effort. Here's some things administrators love. They love a positive attitude. So when you go in, be enthusiastic about what what you're doing. You have just found the answer to a very serious problem, and boy, you know how to do this. Yes. They also love problems with solutions attached. So again, if you are identifying a problem, go in with an idea of how you're going to fix it. They also love solutions with no attendant risk that cost nothing. But they're also not stupid, and they're not so naive as to think that such a thing exists. So, they will understand that any solution is going to have a certain amount of risk and it's going to cost something. So you might as well be upfront about, what are the potential risks and what it's going to cost. This is another reason that oftentimes our projects work well as pilot projects, because a pilot project allows the institution to look for grant funding. It allows it to try something with a limited time frame. So we can do it for 2 years and see how it works, right? It means we can do it in a limited part of the system. So we're just going to do this in the emergency room, so it doesn't, we're not trying to implement an unknown in everything, every part of the hospital. So pilot projects are more likely to get accepted and funded than trying to make major changes in the entire system all at once. And this allows you to run your project for a couple of years and work out all the kinks before you try to go institution-wide with it. They love change over time. So I always recommend doing, if you have changes that need to be made, think in terms of a 3 to 5 year work plan. Not, we're going to do it all next year, but what are we going to do next year? Then what are we going to do the following year? And what are we going to do the following year? So we have a 3-year plan. That means that a senior administration can plan for these things, and we have gradual change over time, as opposed to trying to make brutal change next year. They also love being on the cutting edge. So if you can somehow show that what you're doing is, will make them better than their competitors, or make them, something new that's being tried that other places has been successful, that's always a big selling point. And for some reason, they love technology. Why is that? What is up with that? I do not know. But, at hospitals where we couldn't get a hospital system to think about hiring more interpreters, they would spend many times the amount they would have spent on interpreter salaries to put in a video interpreting system. Everybody just loved the video. They thought that was so cool. I don't know. I don't understand it, but I have seen it happen so many times, I thought I would mention it. Okay, so here's the summary. The C-suite has a lot on its collective mind, right? They got a lot to worry about. So we know that language access issues are very important. And even if the top administrators don't seem to recognize it sometimes. So in order to get their attention, we need to do our research first, carefully define what we would like to do and why, get our allies on board so that we have support from doctors, nurses, other people, maybe from the maybe from the person who is involved with risk assessment for the hospital, maybe with your legal department. Find out who are the allies that are going to be able to back you up. And then prepare your arguments very carefully before you go forward so that you can answer their questions and you can make a very compelling argument. And if the answer is no, don't give up. Try again. Sometimes a no this year is a yes next year, right? Or sometimes you can tweak your project and try it again. And sometimes you can find out just what you needed to tweak to get it to be acceptable. So remember why we do this work, right? It's because of them, our patients. They need this. So if we can't get it through the first time, we keep trying, try a different way, try it in a different format, try it next year, but don't just give up. Okay, here's a couple of resources I put in here. This is a great website, lep.gov, out of the federal government. It's got lots of great resources here. This is a really interesting article by Ed Martinez, who used to be head of the American Public Health Association. No, what is it? The National Association of Public Hospitals, I'm sorry. And he has been for many years hospital CEO. And so he wrote a really interesting article to them from somebody who could speak their language. So that's what it comes down to. We need to be able to present this in a way that makes sense from senior leadership's point of view. All right, I've got 5 more minutes, so I'm going to stop here and see if there's any questions. Stop share. There we go. Did anything come in through the chat, or are there any questions anybody would like to ask, or a story that anybody would like to share? Was this at all useful?
Thank
So
you.
one of the tiles says Outlook web app. It says exactly.
This was extremely useful. I hope you can hear me. Your presentation was wonderful. And as a matter of fact, in my hospital, I work at Children's Hospital in Oakland. We do have a diversity, equity, inclusion, and anti-racism council, and I am part of it. And language access is very important. And because of them, I actually got a grant this last year to study a little bit of the language access. And it's called the Golden Hour of Translation. So Courtney brought me in because of that, and really appreciate it. But your information is absolutely valuable. And the bottom line is that if there's language access, patients get to leave earlier with the correct information. They don't have the bounce back, and what's the other thing? I said safety issues. If parents or families are provided proper interpreter services, there's better safety in terms of medications, the type of medications they're receiving and why they're receiving it, because they have proper interpretation. So all of the reasons, everything above.
When I train providers on working with interpreters or talk to administrators, I break out the reasons why they should be worried about language access into 4 big pots. One is access.
Oh, wait, I'm sorry. Let's try
Better
that.
language access.
Oh, not my regular. Yeah, let's try.
Thank you, Ada. Better language access services leads to better access to care. And in fact, we know that without language access services, LEP patients have very bad access to care. And that means that they end up coming into the ED later, sicker, and their care is much more expensive. Aside from the human suffering, I mean, I shouldn't have to say that, right? Why is it all about the money? The human suffering should be enough. The second reason I always say is quality of care. If you're a physician, you can't do your job across languages if you don't have a good interpreter. Those, how many 24 years of study that you've done, all of those years of training, they come up against a brick wall if you don't have a good interpreter. I always say to providers, you're only as good as your interpreter. So, quality of care goes up when you have qualified interpreters providing language access. We know that the cost of care, I won't say that it goes down, but it definitely is controlled when you have language access because of all these things that, were just said, and also all sorts of other things. Clinic throughput is faster. You don't get people hung up. We don't get people coming back for the same thing over and over again. We don't go down inappropriate roads for diagnosis. You know, we can make an accurate diagnosis more quickly with fewer tests. And finally, there's the legal and accreditation arguments. So legal arguments, financial arguments, quality of care arguments, and access are all arguments that we can make. And all of this is backed up by research as well. And I loved the note, you know, and I am not sure how to pronounce your name. I'm sorry. Is it Ada or Ade or?
It's Ada.
Ada.
ADA. I pronounce it ADA. Ada.
Ada. Okay,
Okay.
thank you, Ada.
Mhm.
And Ada was saying, you know, look at how clever that was. You get a grant to do a study, right? And you might feel like, oh, geez, we're going to spend our lives doing studies. But once you get the studies, that's going to give you the numbers that you need. And that's going to give you those concrete arguments that you can then take to senior leadership about whatever change it is that you want to be making.
Thank you. I know we're at the top of the hour and I just want to be respectful of the time, but Cindy, thank you for sharing your experience around speaking with the C-suite. I think research, you know, defining, and the allies. Those are like the three things that I pulled. And also thanks for the reminder around why we do this work. I think that is so genuinely important. And thanks to our audience today. Thanks everybody for being here. And Cindy, we'll be in touch. Don't you worry. I heard about another talk that you can give, and we will be in touch. But, you know, huge thanks to Veronica for connecting us.
Yes, of course.
I appreciate you as well. And to Efenwa and Valencia for being on, and James, thank you. So we'll be in touch, and thank you so much. And
Thank you, everybody.
And
keep doing your great work. What you're doing is so important, and keep it up. So many people depend on you.
I agree. Ada's doing a good job showing us how to do that one little step at a time. So keep up the great work. All right, everybody, take care.
Okay, thank you. Bye.
Bye.